Hello, hello everybody. Hi Iceland, hi Reykjavík. Thank you very much. I'm not sure I can beat that as an introduction, but you know, we're all friends here and the night is young. So, my name is Ben. I'm a consultant psychiatrist in child and adolescent psychiatry. Been working in the field of addictions for 10 years, child and adolescent mental health care before that, working with abused and maltreated children. Watched that developmental pathway from childhood trauma and abuse into substance misuse and addiction. And the natural developmental pathway beyond that is psychedelics, because for too long psychiatry has been laboring in this maintenance biological model, daily drugs to mask symptoms that don't get you better. And that doesn't work when you have ingrained solid narratives as a result of childhood trauma. So we see across the board in psychiatry, in all our treatments, for all our disorders, they are suboptimal. In fact, there are no other branches of medicine that would begin to accept the kind of levels of suboptimal outcomes that we do in psychiatry. We've become used to this. We've become palliative care type doctors, looking after people, patching them up, but not curing them. We don't even use the cure word. It's a dirty word in psychiatry. Why can't we cure people? Why can't we get them better? I don't want to be a psychiatrist. I want to be an orthopedic surgeon. I want to mend that broken leg, kick them out of my clinic and never see them again. Why can't we do that in psychiatry? We get alongside them for the next 60 years of their life, patching them up. It's not good enough after 100 years of modern psychiatry. Psychedelics offer us the best new innovative technology that we've had for over 75 years in psychopharmacology. We need to start this journey. So, the reason we chose alcohol addiction is because addictions are big. Now, there's a lot of exciting, sexy subjects being covered with psychedelics, but I like the big public healthcare things. The big things, the things that are very costly, the things that have poor treatments, and the things with high prevalence rates. And addictions is certainly up there. Nicotine addiction is obviously the biggest, and alcohol addiction is big too, representing 5% of the world population with alcohol dependence. This is much higher when you look at harmful use of alcohol. And from a financial point of view, that's a huge amount of market, if you like, that we are throwing away money on, throwing good money at bad. And as an addiction psychiatrist and the others in the room who work in addictions, you will know this, I've lost the count from the number of times I've put people through expensive, inpatient, post-alcohol detox rehabs at the cost of £50,000, £60,000 for 6 months, and on the last day, they walk out straight into the pub. I've seen it so many times. We are throwing good money at bad. If we can develop new, shorter, briefer, more effective outpatient treatments at a fraction of the cost, then psychedelics are not only the right moral and ethical and clinical thing to do, but they're also the right financial thing to do. We will save the public purse by using psychedelic therapies to address long-term, large prevalence disorders. Poor outcomes there. Post-detox, up to 90% of people with AUD, with the very best that modern medicine can throw at the post-alcoholic, 90% of people are back to pre-detox drinking levels within 12 months. Psychiatry, this is not good enough. Now, the history of psychedelics in addictions goes right back to the very beginning. In fact, most people don't know this, but the majority, the largest number of research studies and patients seen in the 1950s and early 60s with LSD psychotherapy was for alcohol use disorder. And that was this somewhat serendipitous discovery by the team in Canada that they... So there's this condition called the delirium tremens, the DTs. It's a dangerous toxic psychosis that occurs when you suddenly stop drinking. If you're a heavy daily drinker and you suddenly stop, within 2 or 3 days, you'll experience this extreme physiological reaction called delirium tremens, which presents with an organic psychosis, but also a lot of physiological problems. About 15% of people will die with the DTs. And you get this terrifying organic psychosis. Now, what's weird about the DTs in alcoholism, around about 5 to 10% of people who get the DTs never drink again because they've been so terrified by this organic psychosis that they just go on to sobriety. Sometimes people call that hitting rock bottom. Now, in the early 50s, Osmond and Hoffer in Canada, I won't attempt to pronounce the name of the place, I just say Canada. Saskatchewan, is that right? They had this new molecule coming out of this lab in Switzerland, Delicid, LSD-25. It says on the bottle, induces an organic psychosis, but perfectly safely. That, wow, great, let's give this to our alcoholics. We'll induce an organic psychosis. We'll scare the willies out of them. and it'll do the same as the DTs, but safely. They did it. Not only, A, did it not scare the willies out of them, they actually quite liked it, it was blissful and transcendent, but B, they had tremendous rates of abstinence, 90% abstinence at 12 months, which is the opposite of what we see today, 90% relapse at 12 months. So the very beginnings of psychedelic therapy with LSD was to treat alcoholics. So that was back then in Canada. That study's been repeated with psilocybin in modern times by Michael Bogenschutz, who used psilocybin to demonstrate improved rates of abstinence, found that the greater the spiritual effect, the better the rates of abstinence. There we got Matt Johnson there at Johns Hopkins University, used psilocybin therapy to treat nicotine addiction. Nicotine addiction is a really weird, tricky one. It sort of crosses all the social economics classes, unlike most of the other addictions that tend to cluster in the lower social economic classes. Everybody smokes from all different classes. They found what Matt found with psilocybin, again, the greater the psychedelic, mystical, spiritual effect, the greater rates of relapse. Smoking cessation, very difficult to treat smoking. Evgeny Krupitsky at the Pavlov Institute in Russia. I'd love to go to the Pavlov Institute just to press the doorbell and see what happens. He used very high dose, mystical dose ketamine to treat alcohol use disorder with very high rates of abstinence. And in modern times, Celia Morgan, who's Professor Morgan, a colleague of mine at AWAKN Life Sciences, used ketamine-assisted psychedelic therapy on a phase 2b study to demonstrate its use in alcohol use disorder. So a rich history of psychedelics in the field of addictions. What all of these studies have in common is the greater the psychedelic, mystical, spiritual effect, the greater the rates of abstinence. You have to blow open the head with this time bomb of like complete shift of everything you know in order to break these solid narratives. So bear that in mind when we move on to 3,4-methyl-methamphetamine, a most wonderful molecule. If you were going to invent a molecule to treat trauma, you would come up with MDMA. So how does MDMA work? Well, lots of different ways. Some people just say, oh, it raises serotonin. It's a bit more complex than that. At the 5-HT1A and 1B receptors, it has the effect of reducing anxiety and depression, boosting positive feelings, creating, dare I use the word, ecstasy or the euphoria sense. This is very good for psychotherapy. Positive felt affect. I remember a patient on MDMA turning to me and saying, Ben, she was in a session and she was very loved up, and she said, Ben, is this what love feels like? And I looked at her and I thought, well, obviously, this is a transient, drug-induced experience. Love is this wonderful, noble thing that you spend years building and fostering. You've just taken a drug, it's going to wear off in a few hours. Of course, this isn't love. And then I thought, she's warm, she's held, she's contained, she's trusting, she's empathic. And I said, yeah, this is what love feels like. And she went, oh, wow, I've never had this feeling. I've never had this feeling because since I was a tiny child, I've been kicked, I've been beaten, I've been raped, I've been humiliated, I've been frightened, and I've been scared. And I've never had this feeling inside me. And I said to her, you are capable of this feeling. The drug didn't do this. The drug uncovered stuff in you, but that capacity for love that this drug has shown you is in you. And then after that, she did so well because she had a platform on which to build. She was capable of this. You don't have to stay high forever. The drug can teach you that you're capable of this. So that 5-HT1A and 1B effect is very important. We have a mild effect at the 2A receptors, which is where the classic psychedelics, LSD, psilocybin, DMT work, but much less so and much less intensely than those classic psychedelics. So a little bit of change in the way you look at things, change in the meaning of things, seeing old things in new ways, but without the ego dissolution and the gross perceptual disturbances that you get with classics. So just a little hint of that. Then you've got this peculiar paradoxical effect. The amphetamine part of the molecule produces this stimulatory effect. That's good. That enhances the patient, motivates them to engage in therapy, whilst at the same time, paradoxically, a relaxation effect via the alpha receptors. Relaxation is very important because recall of painful traumatic memories results in agitation. So what you're doing is you're taking the edge off that hypervigilance effect that comes from painful trauma memory recall. So Between those two things, stimulation and relaxation, you're into what we call the optimal arousal zone, the perfect place for psychotherapy. And anyone in the audience who might have tried the drug ecstasy, and you all look pretty groovy, would perhaps recognize that peculiar sensation with ecstasy of being both speeded up and slowed down at the same time. And that's this optimal arousal zone, excuse me. Water balance, very important. Not too much, not too little. Right. And then finally, we have a hormonal effect at the hypothalamus with the release of oxytocin. And as you know, oxytocin is the hormone released from the brains of breastfeeding mothers that engenders a sense of connection and empathy and bonding. So when we add these things all together, what we have is this perfect tool for psychotherapy. It's short-acting, 2 to 6 hours, makes it clinically deliverable. Without the perceptual disturbance, the classic psychedelics, almost always pleasurable. That's really, really important. It's really important when developing a drug that has clinical deliverability is that it's tolerated. Classic psychedelics, LSD, psilocybin, DMT, etc., all fantastic compounds, but they can be difficult experiences for some people. In fact, some people just don't even want to think about doing that, but they would take MDMA. And we see this epidemiologically. In the UK, we have about 750,000 doses of ecstasy taken every weekend, 750,000 every weekend, consistently for the last 30 years. And we're on about 10 to 20,000 doses of magic mushrooms every weekend. So there's a reason why people choose ecstasy over magic mushrooms. It's kind of easier. Now, clinically, that means it's a really much more tolerable tool. Safe. I've been talking about MDMA for 15 years. I used to put up graphs of brains and all kinds of things and neurocognitive tests. I just don't bother anymore. Hear it from me now. And this is a non-biased scientific opinion. MDMA is very, 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 very safe. Okay? It just is. The data is very clear. Now, it is not 100% safe. Lots of things are dangerous. Love, water, lions. But even with massive recreational use, the rates of morbidity or mortality are staggeringly low. And where harm does occur with recreational ecstasy, all of that can be reduced right down even further if the drugs weren't prohibited. Drugs don't kill people, prohibition does. Every single drug death I've dealt with, every single drug harm I've dealt with has been as a result of the prohibition of the drug. So we are increasing danger and harm when we stick our heads in the sand and pretend we've solved the drug problem by banning it. But it's this access to painful memories and enhancements of empathy. So when we add up all these different effects, what it does is it selectively inhibits the fear response, but it leaves the other faculties intact. And that's an important sentence. Many drugs inhibit fear response. A bag of heroin inhibits your fear response. A bottle of vodka inhibits your fear response. That's why those are the chosen drugs for people with trauma. Just blunt the edges. But those are messy drugs. You can't work on heroin or alcohol. You can't do psychotherapy. MDMA so beautifully and perfectly and uniquely pharmacologically turns off the amygdala, the part of the brain that focuses our fear response and produces this fear response in response to a painful environment. Turns that off, but just that. Allowing you to do psychotherapy. You can talk, you can remember, you can recall, you can talk about your childhood, and crucially, the next day when the drug's worn off, you can still remember what you went through. That's a very, very important part, this turning off of the fear response. And I'll quote an anecdote again here. It's in that Netflix documentary. I remember 1990, I was 18 years old. We'd come back from a rave. You know, I was just there to observe. We were like lying around in someone's house, just chilling out, and everyone was going, "Oh man, so beautiful." And someone said, "Oh wow, let's imagine the worst thing in the world." And we all lay there going, "Oh, let's imagine our mums dying." And we went, "It's not that bad." And I didn't know about MDMA therapy at this point. But that's kind of what we do in MDMA therapy. You put the patient into a position where they can go to difficult, forbidden, avoidant thoughts and memories that they normally would not touch. And then that allows you to do the psychotherapy and help them to overcome it. So, oh look, a physiology lesson. So let's think of the brain in 3 different areas. This is really basic, the brainstem. That does your blood chemistry, blood temperature, blood pressure, heart rate, breathing and stuff. Really basic. Cockroaches have that. We move up the evolutionary scale to the midbrain here, sometimes called the mammalian brain because mammals have this. This is where we can process fear. We can change our position in response to fear, a fearful environment. And the red bit here is in the limbic system called the amygdala. It's what we call a top-up instinctive knee-jerk reaction. If a lion comes running at me now, the amygdala will flash and it will trigger a hormonal response called fight, flight, fear. It gets me sort of dealing with the situation. No brain power required, it's just knee-jerk. We move up the evolutionary scale further to the prefrontal cortex. This is the sophisticated brain of the human being, where we have our lofty pursuits like reason and judgment and critical thinking and planning. Most mammals don't really have that to a great extent. Humans have it hugely. And these two areas are in communication with each other. So sometimes you can be in a fearful position and your knee-jerk reaction is run away or fight. And then the prefrontal cortex kicks in a second later, or way less than a second, and says, actually, you know, you could reason with this. It's not so bad. I think we can work this out. Besides, that lion is behind bars. You're at the zoo. So you have this relationship. Now, if you grow up as a child and you are beaten and kicked and burned with cigarettes and humiliated and raped every single day, every time that caregiver comes into the room, you don't know whether you're going to survive. You develop symptoms of PTSD and you develop physical brain changes. Your brain physically changes as a result of that traumatic environment. You get an enhanced amygdala. You have excess activity and network connections within the amygdala. It's good to be scared. This is a positive neuroadaptive response. You have a shrunken prefrontal cortex. There's no point in seeing the good in people. There's no point in talking yourself out of fear. Fear keeps you alive. Indeed, the entire diagnosis of PTSD could be seen as a sign of a healthy brain. Of course you should be scared of everything. People are trying to kill you. So a lot of these, a lot of mental disorders, not that I'm a big fan of categorical diagnoses at all, they make sense. They're the brain doing the right thing to try and bring you back to equilibrium. So you grow up with a physically different brain damaged state as a result of childhood trauma. Now, what MDMA does is the exact opposite. MDMA shuts down the amygdala, dampens that response. Things that normally would frighten you, you can bear. And it boosts the prefrontal cortex. Things that normally you would be scared of are interesting and fun and loving. And this provides this amazing sense for empathy and ability to engage with the pain that you've been through in a more cognitive way. I remember a patient saying to me, I cannot condone or forgive what my father did to me. This is on MDMA, but he must have been in a really, really bad way to have done that to his 6-year-old daughter. Now, that's amazing. You can sit in therapy for 30 years and not get that kind of empathic response. The ability of the survivor of sexual abuse to empathize with the person who did it and see it through their eyes. An extraordinary level of empathy that we see with MDMA. So this study was done, an imaging study by a team at Imperial. So, putting all this together, knowing the work that MAPS had done with PTSD, we had an opportunity, very luckily through a very generous financial donation, to do an MDMA study. We were going to do a study with imaging for PTSD, but I'm really not that interested in imaging. And then this guy came along with a massive load of money and said, what else could you do if I gave you this money? And I said, I'd drop the imaging study and I'd do something which I'm much more interested in, which is alcohol use disorder with MDMA. It's never been done, world's first. And he went, go for it. So we started the world's first MDMA addiction study. Now, the premise for this was that we know that MDMA works for PTSD through all of those mechanisms I described around early childhood trauma and MDMA dampening the amygdala and allowing you to do effective psychotherapy in this usually resistant patient. But going back to those early slides, what MDMA doesn't do very, very often is produce this psycho-spiritual, mystical effect. And as I said from those early slides, all of those early studies, the stuff back in Saskatchewan, and and Bogenschutz since then, and Krupitsky with ketamine, and Matt Johnson, they all found sobriety comes from this mind-blowing peak mystical experience. Now, MDMA, first-time threshold dose users, about 5 to 10% of people will talk about mystical experiences. This is with recreational ecstasy. They'll talk about seeing God and communing with the oneness, that kind of stuff. 5 to 10% is pretty low. Nothing like the 70 to 80% of people who report that with their first-time LSD and psilocybin. So we thought, it doesn't have that mystical effect. Will it work? But basing our work on the work of MAPS and the effects on empathy and the effects on trauma, and also basing the fact that we know the majority of people with long-term alcohol use disorder have trauma, we put 2 and 2 together and we thought, well, it might work through the trauma effect, not the psychospiritual effect. I've always sort of seen alcohol use disorder as essentially PTSD with alcohol. All of our patients had big T or little t trauma. We sometimes call big T trauma the big things like physical abuse, sexual abuse, the stuff that kind of hits the radar for social services, but never take your eye off the ball with what we call little t trauma, neglect, emotional abuse. It's profoundly damaging to the development of a person's psyche. I don't love you. Your dad doesn't love you. We didn't want a boy, we wanted a girl. You're stupid, you're fat. That picture you just drew, that's rubbish. Anyone could have done that. That drip, drip, drip emotional abuse throughout childhood, no physical abuse, no sexual abuse, that kind of emotional abuse is profoundly damaging to the development of psyche and personality. So all of our patients had some degree of childhood trauma. So we did an open label safety and tolerability study, no control group, no placebo. And I'm sure you're thinking, that's not very methodologically sound, Dr. Sessa. But that's what you have to do. First drug in a new condition, you have to start with a safety and tolerability study, a phase 2A study, because it's never been done before. So they all got MDMA. We knew they got MDMA. They knew they got MDMA. We were testing the safety and the tolerability rather than the efficacy. It was an 8-week course in which they took MDMA on 2 occasions, spaced 3 weeks apart, alongside drug, not non-drug prep sessions, and followed by integration sessions. It was a male-female dyadic pair, myself and Dr. Higbed, trained with, under Michael and Annie Mithofer in the States, under the MAPS program, receiving MDMA as part of that training. And we carried this out in Bristol. Bristol's sick, you must come to Bristol. It's the San Francisco of the UK, but better, because apparently San Francisco's not that great anymore, but like it used to be maybe. It's just outside London, which is okay. And it was sponsored by Imperial College London. So this is what the program looked like. So all of our patients were daily heavy drinkers, or almost daily heavy drinkers in some cases. They all underwent a detox. Now, it's very easy to get someone off alcohol, very easy to get them to stop drinking. It's a 7 to 10 day program of daily benzodiazepines, reducing the dose down to 0. By 10 days, they are dry. They don't need alcohol, they're not going to have a seizure, they're not going to have the DTs, they're alcohol-free. So it's pretty easy to detox them off alcohol. The hard thing is keeping them off alcohol and preventing relapse. So they all underwent a detox and came into the program dry. Now, this is a pretty typical protocol, and this is really important. All psychedelic protocols must have non-drug sessions. It's not just about taking the drug. You have to have guided drug sessions sandwiched between preparation sessions and, crucially, integration sessions. And if you miss those other bits out, that's where things go wrong for you. And this is sometimes this is one of the problems with some underground therapies. They tend to miss this out. I get a lot of people calling me saying, Dr. Sessa, can I get mushrooms? Can I get MDMA? Can you give me them? And I'm like, well, no, I can't, because they're not medicines, they're research chemicals, but they might soon be medicines. And we'll give you ketamine. But, so I say, no, I'm sorry, I can't do that. And they'll go, okay, well, I know this guy who's gonna, for £1,000 give me mushrooms in his yurt. And I'll say, great. And then they say, have you got any tips about what I should ask him about this? And I say, go and ask your mushroom guy, will he see you for 3 weeks before the mushrooms and 3 weeks after the mushrooms? And they come back to me and go, no, he doesn't do that. He just gives me the shrooms. And so that's the bit that missed out. So this could be a protocol for pretty much any psychedelic. This could be LSD, DMT, ketamine, psilocybin. It's actually MDMA. But the crucial thing being is we have a combination of non-drug, drug, and post-drug sessions. So they take MDMA twice, 125 milligrams on each occasion, followed by half that dose, 62.5 milligrams, on 2 sessions, and those are day-long sessions, 8-hour sessions. And then we followed them up 3, 6, up to 9 months to collect their outcomes. Clinical MDMA is not recreational ecstasy. I think that's the take-home message there. We cannot make inferences about clinical MDMA based on ravers, you know? What are ravers? What is ecstasy? Ecstasy is whatever dirty powder or weird Superman-shaped pill someone's just given you. Could have anything in it. It can be anywhere between 0 and 350 milligrams of ecstasy, plus or minus all sorts of other things. So it's very important not to conflate those two things, yet that's what the media do, which is absurd. It's like, imagine there was some weird pastime where people like to take the appendix out of the kitchen table with a pair of rusty scissors at home. You wouldn't turn to surgeons and say, oh, you shouldn't be doing appendectomies because I heard about this guy who took out his appendix with a pair of rusty scissors. It's absurd. Yet the media conflate that. Our own medical profession conflate that. Clinical MDMA is different from recreational ecstasy. Even so, even looking at recreational ecstasy, it is very, 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 very safe. People have been taking it in huge amounts for a long, long time, and we have very, very low rates of morbidity and mortality. But we have to keep pushing this issue that clinical MDMA is different. So, nevertheless, in their wisdom, the ethics committee wanted us to look very closely at physiological effects. This is the pooled results over 26 sessions. The green line is drug effects, which thankfully went up, or we'd get a new dealer. What's kind of interesting here is you see a little boost at the 2-hour mark when they get the booster. They started out a little bit anxious because they were a bit anxious. That came down to 0 over the course of the drug effects. And then we have this very neat sort of take-off plateau landing effect of blood pressure, heart rate, and pulse and temperature. So all staying within physiological normal levels. MDMA, more so than classic drugs like psilocybin and LSD, does have a bit more of a physical toll on the body. It does have cardiovascular effects, and that's fine though. With screened and monitored patients, that's perfectly manageable. I love this table because it's so spectacularly boring. It's so spectacularly boring, and it says absolutely nothing of any interest whatsoever, which is exactly what you want in a safety and tolerability data table. No one died. All their ECGs were normal afterwards. All their bloods were normal. No serious adverse events. They all said it was great. They all tolerated it. No suicide. So that's kind of fantastically boring, excellent data. Now, one thing that people often ask me is, what about come downs? What about come downs? And so there's 2 kind of adverse effects that recreational ecstasy users report. One is come downs, so this is acute low affect as the drug wears off towards the end of the experience at the sort of 6-hour mark. And the second is this affect drop 2 or 3 days later, which people call Blue Monday or Black Tuesday or Suicide Wednesday, or there's all kinds of terms. I'm too old to know what they are now. And what happens if you give this to patients who are maybe depressed or with PTSD? Are we just going to trigger that? Now, across 26 sessions, we measured affect, mood, and suicidality daily after each drug session with a telephone call of how they're feeling. Now, on this, the profile mood states, POMS scale, a score of 0 is like euthymia, just nothing. Positive scores are depression and low mood. Anything in the negative is not only not depression, it's higher mood, it's elevation of mood, it's positivity. And as you can see across the pooled results of the 2 different sessions, everybody had a great mood. For the whole day afterwards, we saw no come downs at the end of the session, and we saw no low mood for the rest of the week. Indeed, they had this kind of afterglow effect. Now, this contrasts starkly with what we hear from recreational drug users and with ecstasy. And this means, again, why we mustn't conflate the 2. And look at the way that people take ecstasy in the community. It tends to be taken at night. It's a party drug. The way a lot of people take LSD and psilocybin is a bit closer to how we might do it pseudo-clinically. people, you know, when you take LSD or psilocybin, it's just a few of you sitting around a candle listening to Pink Floyd in the semi-darkness. And that's kind of close to what we do clinically, but weirdly, ecstasy is taken in a very different way to the way we use it clinically. What do? You go to the pub, you drink 2 pints, you take a pill at midnight, you go to a club, you drink another 2 pints, do another pill at 2 a.m., go back to someone's house, drink some wine, snort some cocaine, do some amphetamine, smoke some spliffs, stay up all night. Sunday night, maybe have a small cup of soup, get 3 hours sleep, and you go into work on Monday, and then you feel a bit, and then you say, oh man, it's that MDMA serotonin depletion. It's a hangover. It's a hangover. You've been enlarging it all weekend. And if you take ecstasy, MDMA, clinically, as we do, you come into the clinic after a good night's sleep, you have the medicine at 9:30 in the morning, you work really hard with your therapist all day, who you've been building up a relationship, and you're there with a specific agenda. The drug wears off by 5 or 6 in the evening. You're very chilled, you're in a great environment, surrounded by other people, you've not taken any other drugs, and you've had perfect fluid balance, and you haven't been dancing crazily. You feel great, and it stays like that. Now, that was the results of our study. Now, the MAPS data from all their studies is pretty similar. Certainly, people do report some degree of tiredness and feeling a bit worn out the next day with clinical MDMA, but we're not seeing this massive drop in mood and affect that you get with recreational use. And it's due to those multiple confounding factors. So again, let's not conflate MDMA clinically with what people do recreationally. So how do we do? Now, it took us ages to get the MDMA because it had to be 99.98% pure, and the chemists had to recrystallize it 6 times, and we lost lots of yield, and we finally got it. And in that time, we thought, well, we're not going to do a control group because it's just a phase 2A study. There's no control group. Let's do a treatment as usual group. So using all the same scales and inclusion and exclusion criteria, we just looked at, with an observational study, a similar bunch of people going through detoxes and treatment in Bristol, but with no intervention from us. So they're all heavily drinking before detox. They come down to 0 at detox. We then didn't touch them. We just left them alone, and we picked them up at 3, 6, and 9 months. And very sadly, but not unexpectedly, they pretty much returned to pre-detox levels of drinking. Now, let me be clear. This means they did not, we're not saying they didn't get treatment. They got the very best gold standard treatment that modern medicine gives the post-detox alcoholic. They got the lot. Anti-craving drugs, inpatient rehab, MAPS groups, one-to-one, individual therapy, AA. They got what we do for alcoholics. Yet, by 9 months, may as well have not bothered. So that's the sad state of how current treatment of AUD is. And that's the results from our MDMA study. Came in with high level of drinking at 9 months, 18.7 units per week. Now, what I've done is superimpose these 2 graphs onto each other, and I've changed the scale to reflect whether or not they have a diagnosis of AUD based on over 14 units a week. So they all come in at 100%. The red group is the outcomes observational study, and the black group is the MDMA study. Staggering result, 21% versus 75%. You do not see results like that in psychopharmacology studies. Staggering result, but let's not forget, these are 2 different studies. These are not randomized arms of the same group. It might not be the MDMA at all. It might be the wonderful therapists. So the next phase, obviously, is to take this into phase 2B and then phase 3 with a placebo group and randomization. And we are doing that at AWAKN Life Sciences. We are currently in the process of submitting our clinical trial application for this phase 2B study, and we'll be carrying that out in our clinics. With the idea to see this licensed for alcohol use disorder in the next few years. But it's going to be a long time coming because we have to get this phase 2B and then a phase 3 study done. So it's probably about 5 years away if we're lucky. But that study is now underway, and we're very optimistic about it. Just want to say a little bit about the work that I do with AWAKN. So it's a biotech company, and we're doing this AUD study research. We're doing other research with taking Celia Morgan, who is there, who did the ketamine for AUD study, taking her research into phase 3. So alcohol use disorder with ketamine into phase 3, MDMA into phase 2A, and then into phase 3. And we're also doing some interesting research with Behavioral addictions, gambling, sex addiction, pornography addiction, these are addictions with probably a much higher prevalence than we know, because they tend to be under the radar for services, but are incredibly damaging, and there's a lack of research and certainly a lack of poor outcomes. So that's the research. We're also making some new chemical entities. It's very much flavor of the month, isn't it? So we're looking at maybe a shorter acting entactogen that has similar qualities to MDMA, but might be more clinically deliverable in an NHS setting. And we're opening clinics. We have 4 clinics open at the moment. Bristol, London, Oslo, and Trondheim. We're opening another Oslo clinic. And we're looking at further expansion in Manchester, Dublin, Edinburgh, etc., and maybe aiming for 5 to 10 clinics around the UK and Europe. And we want to be the physical place where people come to get therapy with psychedelics. And here's the thing, we're using ketamine-assisted psychedelic psychotherapy. We are not a ketamine clinic. Don't call us a ketamine clinic. We are a psychedelic medical clinic that just happens to only have ketamine at the moment. Ketamine is an approved licensed psychedelic, not for psychiatric disorders, but as an anesthetic, but you can use it off-label. But we never give ketamine without giving psychotherapy. So I'm trained with MDMA and psilocybin and ketamine. We work in the psychedelic space. And ketamine is an interesting one because the psychedelic space induced by ketamine is exactly what anaesthetists don't want. I can remember giving ketamine when I was doing pediatrics, like to a 10-year-old for dislocated shoulder, and I went to the registrar, I said, I've got this kid, I'm going to give him ketamine, I'm not sure whether to give 75 or 100 milligrams. And he said, whoa, if you're giving ketamine and you're not sure if it's 75 or 100, give 200. Because the one thing you don't want is to induce in an anesthesia is this weird psychedelic experience. So when we use ketamine as an adjunct to psychotherapy, we're actually breaking the golden rule of anesthesia. We're giving too little. Now, this is good because we want that psychedelic experience. What they consider an irritating side effect, we work within that space. The other thing that's good about that is it just shows how non-toxic and safe ketamine is, because we're giving doses 5, sometimes 10 times lower than you'd give a 10-year-old. So ketamine-assisted psychedelic psychotherapy is going on. We're also training psychedelic therapists because we're going to need thousands of those in the next few years. Come and visit our clinics. We have clinics in Bristol, London, Oslo, and Trondheim. It would be lovely if you could come along and meet me and hang out and see the place. They're very beautiful. So the take-home message here around MDMA. Clinically, socially, and economically, it makes sense to use MDMA-assisted psychotherapy. We cannot afford not to do this. We cannot afford to keep throwing old, good money at bad treatments that don't work and ineffective. It's tolerated, it works. So we need to work with regulatory authorities and governments and addiction services, and we need to get this happening because it's worthy for our patients. So I'll stop there and take some questions. Thank you. We've just got 7 minutes for questions, so if anyone has any questions, put your hand up. If not, I'll carry on blabbering for another few minutes. Yeah.
A number of studies, fewer studies by including more people. Oh, sorry. So there are so many studies. Can't we just have fewer studies and more people joining each one? We could like put maybe a 50,000 person study here in Iceland.
Should we have fewer studies with a larger N number?
Yes, like with 50,000, 20,000
Let's do lots
maybe?
of studies with large N numbers. I mean, it just comes down to money, doesn't it? Yeah. I mean, one thing that's interesting about psychedelic studies, this is my personal theory, right, and I might be wrong about this. My sense is that all of the psychedelic drugs work for all conditions, okay? We have developed this pigeonholing in recent years of MDMA for this, psilocybin for that, ketamine for that, DMT for this. My theory is that we're going to get to the point where when we've done every single psychiatric condition with every single psychedelic, we'll realize they all work for all of them. And this pigeonholing we're seeing in recent years is just an artifact of the limited number of studies we've done. Every month we hear another thing. Oh, wow, new study comes out. Apparently ketamine works for anorexia. The next month, oh, wow, new study comes out. Apparently MDMA works for alcohol. Another study comes out, oh, well, apparently psilocybin works for anxiety disorder. Of course they all do. If these are non-specific adjuncts to psychotherapy. So what you could think of is any condition in psychiatry that currently has a psychotherapy treatment program will be treated better by psychedelic-assisted psychotherapy. And the similarities between ketamine, MDMA, and psilocybin are greater than their differences when they're used in the clinical setting. Now, I'm not so naive as to suggest those three drugs are the same. Very different modes of action, very different subjective psychological effects, if anyone's taken all three of those. But when you take a person into the clinic and you do that preparation and you have a guided session with the music and the headphones and the integration, any one of those drugs will work in any condition. This is my prophecy here. And 5, 10, 15 years down the line, when we have all the drugs approved and licensed, the issue is not going to be, oh, you've got social anxiety disorder, psilocybin is the one for you, or you've got PTSD, MDMA is the one for you. The issue is going to be, what would you like to try for your particular condition or presentation? In fact, we're going to do away with the concept of categorical diagnoses as well. We're not going to call them depression, anxiety, eating disorders, PTSD, addictions. We're going to call them, I don't know, trauma-based problems. And psychiatry is going to diverge into neuropsychiatry, where we have epilepsy and ADHD and severe schizophrenia, and then the whole of the rest of psychiatry is going to be called trauma-based disorders. And the patient is going to be at the forefront of their care plans. We're not going to talk about symptoms and diagnoses. We're going to talk about wellness and functioning, and what would you like to do? Patients don't want to get better scores on the BDI. Patients want to get back with their girlfriend, see their kids and get their job back. They want functional improvements. The patient should be driving the care plan, not the psychiatrist, certainly not the diagnostic manuals, nor should we be pigeonholing psychedelics. They will all work for all psychotherapy-based treatments. So that is where I think we're going. So I don't see any more questions, so I'll make another point. The other big challenge for psychiatry, psychedelics at the moment right now, is getting this into public health, okay? I did not do this work to treat rich hippies. These treatments need to be available for free on the public health all over the world for the people who need them. We're in a weird place at the moment where, for years there was no money. No one had any money. We were scraping together 10 grand here, 10 grand there to do some pilot study. 2, 3 years ago, something weird happened. Massive chunk of money came pouring out of the Canadian cannabis business, and sharks were going around everywhere looking for people to set up psychedelic startups, which is great. And we had this huge, last 2 years, this huge loads of psychedelic startups with loads of cash and investment. But there weren't really enough experts around the world to do something with this. And so there's a bit of a kind of treading water situation at the moment. I'm sure it's going to be good. And I support this. What some people consider the word corporatization as a dirty word, I consider it medicalization and accessibility. These drugs, which are so important, have languished in the sort of recreational drug use or underground use with a tiny proportion of people for far too long. We need to make these accessible to people all over the world. People who don't want to break the law, can't afford to fly to Peru and sit in a medicine circle. So we need to make these on the national health and available from doctors and nurses and therapists out of public healthcare systems. That's a bit of a challenge for these startups because they need to make profit, and profit is necessary if you're going to make this business work. Everything we see before us here, the clothes we're wearing, the iPads we're looking at, and all the lights and the cars has come from profit-driven industry. We cannot run the world as a charity. Well, Rick Doblin can, but he's the only person who's managed to do it. Everyone else it has to be profit-driven. And now, I'm a hippie, I'm a socialist, I struggle with that, but it is necessary. But we need to find a way to make this ethical profitable. We don't want to fall down the same trap as the pharma industry of the past. We need to find a way to make this a cottage industry which looks after itself, looks after the indigenous roots of psychedelics, learns from that, learns from the underground, respects the plant medicines and the places where they've come from, but find a clever way to turn this into modern healthcare. We cannot afford not to do this. Psychiatric disorder is epidemic across the world and too expensive, and people are undertreated, and that worsens social situations as well. But we will find a way, and thank you very much. I think I'll stop there. Thank you.